Hi guys, next up is acute rheumatic fever, which is referred in Harrison as a disease of absolute poverty. This is a kid between 5 to 14 years of age who's having recurrent sore throats being caused by group A beta hemolytic streptococcus, and the antibodies that are formed in this condition are cross-reacting with human connective tissue and are damaging the heart valves or causing joint manifestations or causing chorea. So I will talk about modified Jones criteria, the 2015 update for that. I'm also going to talk about pathogenesis, which is type 2 hypersensitivity or molecular mimicry. But if I begin with that, which you have read already in pathology and microbiology, it will sound very repetitive and cliche. So I am going to begin this topic by initially focusing on which has been very frequently asked in at least last 2 to 3 years, that is secondary prophylaxis with respect to rheumatic fever, where we'll be giving injections of benzathine penicillin 3 to 4 weekly. You see, let me say we have a kid who's 10 years of age with rheumatic heart disease, and the commonest valvular lesion in a 10-year-old child with rheumatic heart disease is mitral regurgitation. Yes, it's not mitral stenosis. After 18 years of age, the commonest valvular lesion, understandably, is mitral stenosis because a commissural fusion that will take some time. But if you get a question in which he either mentions a child with rheumatic fever developing rheumatic heart disease, or let me say he says a rheumatic active carditis, then these kids who are landing up in congestive heart failure could be having mitral regurgitation. And the question will say, what would you advise to the mother of this 10-year-old child who's already having a mitral regurgitation, who's already having a persistent valvular disease, which is demonstrable clinically because there would be a pansystolic murmur, and I can even on echocardiography see the jet of blood leaking from LV to LA. Then the duration of antibiotic prophylaxis in this particular case, the options in the MCQ would be like 18, 21, 25, 40, and your answer for a patient who's already having a documented, either clinically or echocardiographically documented valvular lesion, your answer is going to be 40 years. And when you tell this to a mother, I mean, most of the time you can imagine the response of an Indian mother, and she's going to maybe roll her eyes and say, doctor, are you serious? I mean, my kid is 10 years of age and you expect me to come to your clinic till my kid is 40 years of age, he'll be adult by that time, and you want him to come regularly for injections. I mean, doctor, don't you have a better deal? I mean, nowadays patients ask for deals from you. So to satisfy this over anxious mother, you will say that, ma'am, I would recommend that the kid receives this injection even when he's adult till 40 years of age. But if she's not ready for it, then the injection should be taken for at least 10 years after whatever is the last documented attack, after which obviously you as a physician has intervened here. And therefore the main message is that prophylaxis, the secondary prevention component, prophylaxis with benzathine penicillin, will prevent further incremental damage to the heart valves. If these injections are not given, very common in Indian scenario, then the damage in the heart will increase, the neurological manifestations, the arthritis component, I mean, all the standard features that we'll talk about subsequently in modified Jones criteria are bound to deteriorate. Now, suppose he modifies a question where he says that the kid is having rheumatic fever with carditis. I mean, it's not a guarantee that every time there would be a valvular lesion present. I mean, it's not always that you would get a mitral regurgitation developing. There is a possibility. I mean, you see the Ashkoff nodules which are found in this condition, they could be affecting only the myocardium or the pericardium. They can affect all three layers of the heart. The hallmark is obviously endocarditis, agreed. But I'm saying luckily the kid did not have Ashkoff nodules causing damage to the heart valves, but there was a myocarditis component or there was a pericarditis component. So there is a evidence of carditis, but there is no persistent valvular disease present. In those circumstances, the injections would be given up to, I mean, the options would still be the same, 18, 21, 25, and 40. And then the answer of yours would be given as at least till 21 years of age, though it's a bit controversial in a sense that if you read this from OP Ghai, then OP Ghai book says 25 years of age, but okay, we are going by what is the American Heart Association guidelines that's currently given in Harrison. And again, you have that super anxious mother, and she says, doctor, my kid is so small, and you want my kid to be up to age of 21 and still come for injections. I mean, don't you have a second best deal? So you tell her that, okay, ma'am, don't bargain anymore. The best deal I can offer you is at least for minimum of 10 years after the last attack, that your kid should be taking secondary prophylaxis or secondary prevention. And the bottom line is that if the kid is having a penicillin allergy, then we cannot even give benzathine penicillin. Then we shall be using macrolides. If he begins the question by saying a kid is already documented to be having penicillin allergy, you know the risk of anaphylactic shock that can develop, then I would be still continuing antibiotic prophylaxis, but I'll be using macrolides. I can be using erythromycin, or I could be using azithromycin in a kid. The durations remain the same, but the bottom line is, the point is that these are the standard answers which are to be given. And the main emphasis, or the main reason why I'm starting with this topic, is mainly to sensitize you to the fact that in a question you need to look at it carefully, whether there's a valvular lesion present, whether he just says the word carditis without a valvular lesion, or whether he says the word plain rheumatic fever. If he says the word plain rheumatic fever, then your answer is still gonna be, the options are still like 18, 21, 25, and 40 years of age. Then your answer would be, and sometimes he might even mention lifelong. I mean, ideally I would love to give a lifelong, because if I did not have any practical issues with penicillin administration, and compliance with the patient was assured, lifelong would have been great. But then you can understand, no, lifelong is not practical. So I'm not written practical anywhere here, though the textbook says in some scenarios we might be forced to tell the mother lifelong basis, is mainly because of the fact that, see, sore throat, it's not that sore throat cannot occur after 40, no. It can occur, incidence will be lesser, but still it can occur, no. So okay, I mean, that's not a very practical approach. So this is what is the American Heart Association recommendation. This is what you were supposed to answer in the exam. And again, you have this mother who says, well doc, I mean 21 is too long, and can't you give me another approach? Then you will say, okay, 5 years after the last attack, that's the duration of prophylaxis that should be given with benzathine penicillin in a kid. And the standard information, which is valid for all of them, I'm just using a different color to highlight it. I mean, for all three of them, the data is whichever is longer. Like suppose in a question he gives me option, like let's take up the first scenario, rheumatic fever without carditis. And in those circumstances, or I give a worst case scenario, there's already a valvular lesion present in a kid, and he says, would you like to give it for 10 years after the last attacks, or up to 40 years of age? Me as a physician, my advice would be as long as possible. I mean, obviously if a mother is not going to buy that, she's not going to agree to it, we'll have to take into consideration the sensibilities of the mother. But in the exam, this is the data which is to be remembered, whichever is longer. So our first answers are 40 and 21. How to remember this? Very straightforward. If valvular, just check out whether valvular lesion is given in the question or not. It could be echocardiographic finding. He might just say, describe a kid with rheumatic fever who's already suffered from arthritis. He's currently having a pansystolic murmur. Then considering that there is a murmur which is heard, that indicates a valvular lesion, and some findings of congestive heart failure in the kid could have also occurred. Then I would like to max out the duration of antibiotic prophylaxis to 40 years. So whichever is longer is a universal statement which I would like you to remember for all the three permutation combinations that I have currently explained before you. We will next focus on the pathogenesis of this disease. In case acute rheumatic fever is untreated, I mean, I'm just talking about the natural history of the disease per se. If there is no treatment offered, like was the initial scenario when, I mean, people did not have access to good medical care, the course of disease was a suffering of at least 12 weeks. But with treatment now, the progression of the disease or the suffering of the patient is reduced to about 1 to 2 weeks. So you can understand, I mean, why is it important to diagnose this condition, is because you are cutting short the morbidity component. Obviously, mortality can occur. Kid can die due to congestive heart failure if medical facilities are not available. He could have a rheumatic myocarditis or a valvular lesion like severe MR contributing to manifestation of congestive heart failure. But we can cut short the natural progression of the disease. You're not supposed to remember all these values that I'm writing at the moment, 12 weeks or 1 to 2 weeks. This is just to tell you that from a medical standpoint of view, I mean, why are we studying this topic is because we are reducing the morbidity and the mortality component, and we're reducing the suffering of the patient from a huge 3 months to maybe between 1 to 2 weeks when the patient would be feeling relatively better. Now, as far as the pathogenesis is concerned, it's an autoimmune disorder. It's an example of type 2 hypersensitivity reaction. And the alternative term that would be described here is molecular mimicry. I'll explain that molecular mimicry also concept in a while, but you are having self-reactive. I mean, the immune system is attacking self. Now we can take this rectangle to be representation of group A streptococcus bacteria. It's actually, the technical name is group A beta hemolytic streptococcus, and this is notorious to cause two problems. Either it could be causing recurrent sore throats, or it could be causing skin infections as well. Why that's important for you to know is because in the kidney section we read about post streptococcal glomerulonephritis. Even in PSGN, we read about the same organism causing recurrent sore throats and a skin infection. But then post streptococcal glomerulonephritis is a type 3 hypersensitivity reaction, whereas rheumatic fever is type 2 hypersensitivity reaction. And let's look at what is going to happen next. On the surface of this bacteria, we have what is referred as M protein, and obviously if there is going to be any infection in the body, antibodies are also going to be formed. Now these antibodies are supposed to destroy the bacteria, which they'll obviously try to. I mean, the basic function of the antibody is to make the bacteria more vulnerable to the immune system. The antibody will do its job, fix the complement system, the bacteria gets destroyed. But the problem is that the antibodies which are formed in rheumatic fever tends to cross react with components of human connective tissue. They tend to cross react with the endothelium of the heart valves. They tend to cross react with connective tissue in the basal ganglia, so you can get a chorea manifestation. So the question would also arise that the antibody will cross react with what component? I mean, what's the common antigen between the cell wall of this bacteria and also present in human connective tissue, omnipresent in human connective tissue, because of which the antibody will not only do its job, that is to try and destroy the bacteria, but will also start attacking self. This component, which is present everywhere, the technical name is N-acetyl glucosamine. This would be present, this antigen has been documented to be present in the carbohydrate antigen, or the carbohydrate present in the structure of, or present in the wall of the bacteria. And the same antigen is present in human connective tissue as well. It is also present present in the endothelium with respect to the heart valves, because the hallmark feature that you encounter in these patients is rheumatic endocarditis, and we get an acquired heart disease. I mean, the commonest acquired heart disease. In fact, I can just put that on record here. If the question says overall, what is the most common acquired heart disease in developing countries, then your first answer is the topic that we are studying. I mean, this is valid obviously for countries like India, which where the medical facilities, especially in the periphery, might be lesser, to the level that a patient is having a simple sore throat of bacterial origin and he goes without treatment. Sometimes there could be subclinical infection as well. So rheumatic fever, or ARF as it might be written, is overall the commonest acquired heart disease in developing countries. The peak age of onset of this disease is between 5 to 14 years of age. That's the peak age of onset, and this disease has been found to be relatively rare after 30 years of age. So most patients are either going to be, adolescents, or like you will also notice one more interesting fact which I can say. I can just correlate this with OBGY, that rheumatic heart disease is more common in female patients. Even when you taught about medical illnesses complicating pregnancy, they always talk about valvular lesion mitral stenosis. They always talk about a mid-diastolic murmur of mitral stenosis being auscultated in a lady who's pregnant. She's from rural India, and most of the time she's not even aware of the fact that she's carrying a heart disease till she conceives. And that's when the heart, because the heart has to work harder in pregnancy. So lots of time these women with rheumatic heart disease, they used to get tired early, they used to feel breathless, but they never were detected due to lack of medical care. And now when she's pregnant and she's coming for an antenatal checkup, and she complains of this breathlessness and swelling in the feet, and with the obstetrician is auscultating her, that's where the murmur may be found. And that's when echocardiography will reveal that she's suffering from a mitral stenosis, or mitral stenosis with mitral regurgitation. In fact, I said a very interesting data here. Rheumatic heart disease incidence per se, like I said, it's more common between 5 to 14 years of age. That's okay. But gender wise data, if you look at it, then rheumatic heart disease is more common in female patients as compared to male patients. And in these female patients, when they conceive in future, you could even be having recurrence of chorea, that you read as chorea gravidarum. In contrast, if you look at acute rheumatic fever incidence with respect to men and women, then you will find that the incidence per se is gender neutral, that it's not that it's more common in men or it is more common in females. Acute rheumatic fever, I mean, you may not always have a cardiac involvement, or you may not always have an endocardial involvement occurring in a patient. So acute rheumatic fever incidence is gender wise equal in men and women. But when it comes to heart disease developing, it's more common in female patients. Even neurological feature of Sydenham's chorea will be relatively more common in female patients. And when they conceive in future, I mean, lots of time carditis and chorea, both beginning with C, could be present in a female patient, and she could have recurrence of chorea at the time of pregnancy, which is called as chorea gravidarum. I'll speak more about this when we discuss the clinical manifestations, but he will try to mix up the epidemiological information that I'm telling you, gender wise data, age group wise presentation, and he's going to mix this up with the data and pathology, which is type 2 hypersensitivity, the concept of N-acetylglucosamine, which is a common streptococcal antigen, and this would also be present with respect to the endothelium in the human connective tissue, which is why the antibodies tend to cross react against self. These are cross reactive antibodies, and that's why this is an example of molecular mimicry. Let's now focus on the natural course of disease. I said the usual suffering of the patient would be spanning over 12 weeks. Let's see how it begins. This kid would be 5 to 14 years of age and he's having recurrent sore throats. Following this recurrent sore throats, there can be a latent period of approximately 3 weeks before manifestations will start appearing. The range given in the textbook before manifestations tend to appear is between 1 to 5 weeks. So this kid, recurrent sore throats, why would he be brought to you? He is suffering from recurrent sore throats by group A beta hemolytic streptococcus. This could be developing manifestations like difficulty in walking. The child might be not able to go to school. He might be going to a midday school program, and the child was found to be limping by parents. He was unable to get up in the morning, go to the bathroom, or go and take a bath by himself. Then arthritis is one of the reasons why the patients would be coming to medical attention, and arthritis is rather one of the early manifestations of the disease. In contrast, couple of children might be suffering from carditis as well. It could be perimyo or endocarditis, I mean any of the three manifestations, and a large number of these patients might even remain asymptomatic from the carditis perspective. I mean the heart has ability to compensate, so initially you may not get features of congestive heart failure in these patients. So arthritis and carditis are relatively features that can develop early. If he says which manifestations can be developing late, then chorea, syndrome's chorea can be developing as late as 6 months after the onset of a sore throat. By the time the person will develop neurological feature of chorea, that's involuntary movements, the parents might have even forgotten. I mean, normally when you have a sore throat, after 1 or 2 weeks, you will not even remember that you had a sore throat. Human mind is like that. We tend to forget the unpleasant memories very fast, unless and until they are life threatening. I mean, most of the time we tend to forget about mild medical illnesses. So most of the time, once chorea will develop, the parents may not be able to even recall that the kid had a sore throat. So the question will say which of the following are relatively early features. Then it is arthritis and carditis, and late features that would be occurring is chorea, or sometimes, like I was saying, you might write the word indolent carditis. The meaning of the word indolent is that it is very slowly progressive, because heart may not produce features of acute decompensated congestive heart failure, and in large number of cases, especially due to lack of education in our country, parents may not be able to pinpoint the history of recurrent sore throat as well. In fact, as far as the incidence of chorea is concerned, depending on whichever clinical studies that we look at, we have found that the incidence of development of chorea is ranging between 2 to 30%. That would be because when this study would be done in India, where the disease is more common, because case load is more, chorea incidence will also be more. Let's take up a case, a country or population which would be a low risk population for rheumatic etiology, something like America or Canada. Then I can say that the incidence of chorea, because case load would be less, would be also relatively lesser. So as such, chorea would be between 2 to 30% of cases. That's the incidence of cases that we usually tend to detect. And he can also ask you which of these would be very unlikely to be seen features. Then there are two features which I'll be describing even subsequently: the location of subcutaneous nodules, extensor and distribution. I'll speak more about subcutaneous nodules as we progress. And then there is a feature that is usually not found in the Indian population. Though I'll speak about features of our erythema marginatum, it is not encountered in Indian population because our skin texture is darker as compared to American population. Both of these features, the incidence of this would be less than 5% in both low risk populations as well as high risk populations. So if he just says which of the following features is unlikely or less likely to be seen, then it is subcutaneous nodules and erythema marginatum. If he says late, then it's gonna be chorea. If he says which is early to be developed, it is arthritis. At least three carry home points: arthritis, carditis, both could be occurring early, both could be occurring together. That's why these are two major criteria for diagnosis. But the point is, on a comparison basis, I can say there is a data. In fact, I can just write the data for from Harrison with respect to arthritis. He says about 60 to 75% of cases might be having presentation of arthritis, which is a polyarthritis most of the time. It's going to be migratory polyarthritis involving the large joints like ankle joint, knee joint. It's going to jump from one joint to another. As far as the incidence of carditis is concerned, is mentioned 50 to 75%. So you can notice that both could be developing in a person, or it could be that arthritis, because arthritis mathematically I can say the range given is 60 to 75%. So I wrote it first. So the minimum message is what can develop early. That's gonna be arthritis and carditis, which can develop as late as 6 months after the incidence of a sore throat, and the history of sore throat might even be forgotten. Answer is Korea, and which is less commonly seen or uncommonly seen, subcutaneous nodules and erythema marginatum. And erythema marginatum is not seen in Indian population. Another justification that I can say is, like, when you read the topic of typhoid, all of you would have read about rose spots. Now you would have read about rose spots with respect to typhoid, but you would have never seen it again because of the darker texture of the skin. So in the same spirit, I'm trying to teach you here that erythema marginatum is usually not encountered with respect to Indian population. That's because of the darker texture of the skin. If the case is not managed aggressively, then the natural course of disease would be approximately 12 weeks, and a lot of these patients will develop subsequent damage to the heart valves and will land up in congestive heart failure because of structural damage to the heart. They can be arrhythmias in these patients. In mitral stenosis, there would be left atrial dilatation, so there could be clots in the left atrial appendage due to atrial fibrillation. The clots can go into systemic circulation into the brain, so they can even be stroke. So if we do not intervene, I mean, there's bound to be suffering, and what we can do to mitigate that, obviously I'm going to tell you what are the strategies that we'll be deploying for management of these cases. But we can shorten the suffering of the patient from a whole 3 month period to between 1 to 2 weeks if intervention is done, and we can prevent the further damage. We can prevent the further damage by going ahead with secondary prevention. All of this would have never ever occurred if primary prevention was done. Let me say a kid has a sore throat, and we start oral penicillin or amoxicillin, very cheap drug, oral penicillin, amoxicillin, over the counter, easily available at most chemist shops. If in rural India a kid is having a sore throat, and in case we tend to treat it with help of either oral penicillin or oral amoxicillin within 9 days. I'll write down the data also subsequently. If he asks about primary prevention, this guys that I've taught you is secondary prophylaxis, secondary prevention. If he talks about primary prevention, it is simple. Treat the sore throat. If you treat the sore throat of a patient, if you kill the bacteria, there would be no time for all this mayhem with respect to type 2 hypersensitivity that I was trying to explain. And I did set a point which I did not write at the moment. I will do it, but I would like to repeat that point once again. If sore throat is treated within 9 days of its onset with any of the two, oral penicillin or amoxicillin, then there is a high probability that the person will not develop any of these bad things. That is, chances of development of rheumatic fever will be substantially curtailed. And that is why in the modified Jones criteria, you will also read about low risk population, high risk population. Low risk population would be like America, Canada, where easy availability of antibiotics, good medical care. So as a result of it, the chances of development of all these complications would be lesser. And when I say moderate to high risk population, countries like India or anywhere where there is overcrowding, anytime where in a small shanty in a house there are so many kids, the chances of recurrent sore throats will dramatically increase. Whenever there is more population, there is an overcrowding component present. So I will write down subsequently definitions of low endemicity or low risk population versus high risk population. But the minimum carry home message at the moment is that if he says primary prevention, then your answer is simple: oral antibiotics. It is oral antibiotics. But if he talks about secondary prophylaxis, which is currently on the slide, then it's gonna be injection benzathine penicillin, and this would be given between 3 to 4 weeks. I'll be writing down all of this information in the later part of the discussion, but I had to give you a heads up here because most of the time when we try to approach questions, because we get less time in attempting a question. Usually reading a question would take about maybe 20-25 seconds, reading through the options another 5 seconds per MCQ. So the usual response time is about 15 to 20. That's the usual feedback that I get. I mean, whether you talk to people from NEET 2021 or 22 or 23, they said paper was easy, boss. But it is just that it took a while for me to read the options because it usually takes about a minute or so, and therefore there's a high probability that you might miss words like primary and secondary prevention. And the whole thing can just blow out, in a sense that if it says primary prevention, it's oral antibiotics. If it is within 9 days of onset of a sore throat, a normal course of antibiotics for 5 days, and it's goodbye to no chances of development of rheumatic fever. But with benzathine penicillin, the shots would have to be given on a recurrent basis. You always have to give a test dose before you ever give injectable parenteral penicillin to a patient. And more importantly, the guidelines which I've told you, that's going to be 40, 21 and 21, and then it's going to be 10, 10 and 5. I hope it's remembered by you at the moment. 40, 21, 21, depending on the situations, permutation combinations I created. Backup answers 10, 10 and 5. Next up, I'm going to describe a couple of major manifestations of the disease, and then I'll compile a table where in a single table I'll be telling you the major and the minor criteria. One of the major criteria that we need to remember would be the cardiac involvement, where we could be having any of the three layers of the heart getting involved. That would be pericarditis, myocarditis or endocarditis. What I'm trying to say here is that the Ashkoff nodules could be present in the outermost layer of the heart, causing inflammation, which will cause this child with recurrent sore throats to develop chest pain. And that would make the child start crying, because we don't expect a 5-year-old, 8-year-old kid to be able to explain to you properly that having chest pain. So lots of time this pericarditis can be missed clinically, because if a child is crying, then to be able to hear a pericardial friction rub in a busy OPD will again not be possible. Therefore, in this unconsolable child with recurrent sore throats, what will come to your rescue and identify pericarditis component would be ECG finding of ST elevation, which is different from that of myocardial infarction, because in MI the ST elevation is convex upwards, whereas here this would be a concave upwards. A quick recap, because we have talked about this even earlier. For pericarditis, it's a ST elevation concave upwards. Pericardial friction rub can be heard if the child can be, once the child is consoled, is quiet, in a quiet examination room, you might be able to hear a pericardial friction rub. And to treat this pericarditis component, we can be using steroids, which will be useful. But if these Ashkoff nodules are causing damage to the myocardium, or there is a myocarditis that's happening, then steroids are usually not going to work. Though a lot of physicians give steroids even in rheumatic myocarditis, where the kid ends up with congestive heart failure, but there have been two meta-analyses meta-analysis of all these trials where they have given steroids and they've not found any benefit. So steroids are of questionable benefit with respect to especially the myocarditis component. With pericarditis, understandable, you can reduce the inflammatory component, but with myocarditis per se, if there's a congestive heart failure, what are you going to do in this case? Then your answer would be LMNOP. And as far as steroids are concerned, I've not written it at the moment, because the meta-analysis, as I said, usually shows steroids to be a questionable benefit, though a lot of physicians do tend to give prednisolone even when the person is suffering from myocarditis. The hallmark which would be seen in this patient is the endocarditis component, the heart valve involvement. For the heart valve involvement, most of the time in the exam, they would like to go into a bit of more detail, where one, they would like to ask you what is the valve that would usually be involved. They would also love to ask you regarding what is the valvular lesion that can be anticipated. And more importantly, they can also ask you which surface of the heart valve will be involved. So let me just explain the 3 points to you one by one. First, we'll begin by saying which valve can be involved. So anybody who's gone to a medical school knows the fact that overall the most common valve involved is mitral, and the second one that can be involved is aortic valve. And what's the valvular lesions that would be usually encountered? So in majority of cases, you could be having a mitral regurgitation, or it could be an aortic regurgitation developing in a patient. If he uses the word carditis, that's active carditis in a patient, then your answer would be given as mitral regurgitation or aortic regurgitation. Either of the two can be developing. But if he specifies the patient's age is more than 18 years of age, then because it's a long-standing process, you would be having commissural fusion, and that's when you could be having mitral stenosis. And in hospitals, you would have seen cases where you could be having a combination of MS with MR. Looks a little surprising, no? MS and MR. How, a query that I get lots of time is it possible to have the two together? Yeah, if a door is not going to open properly, it may not even close properly. I repeat that again. If the door will not open properly, stenosis. And if the door will not close properly, regurgitation. So there's a possibility that MS and MR can be coexisting in a patient as well. That's what usually happens in a lot of female patients who are coming to us for a obstetric follow-up, antenatal checkups, where we auscultate them and we might be able to pick up both MS or MR, and one of them might be a dominant lesion as well. But if it does not specify the age group of a patient and he just says active rheumatic carditis, what's the valvular lesion given? Or if he specifies age group like 5-year-old kid, 10-year-old kid, that at 5 or 10 years of age you don't have a stenosis, then you have a development of mitral or aortic regurgitation, which can be demonstrated even echocardiographically. Now, when I say surface of the heart valve involved, I'll just draw a quick line diagram here to represent the Ashkoff nodules involving the heart valves. What I'm trying to say next is, let's assume this, that we are having Ashkoff nodules involving the superior surface of the heart valves, the Ashkoff nodules are involving the inferior surface of the heart valves, but the max concentration would be with respect to the tip of the valves, where the heart valves are approximating each other. This particular area where I put an arrow, this is the specific area where the highest concentration of Ashkoff nodules can be present. So what I've written at the moment before you is important because this is taught even in pathology, that is commissural end involvement. This commissural end involvement is gonna be the reason for development of valvulitis in this patient. You see, mitral stenosis will take some time to develop. If I do a echocardiography in these patients, the echocardiography in these patients, even in early phase of the disease, will show presence of inflammation of the tip of the valve. Why it's important for you to know is because of the fact that if we are going to be having inflammation in the tip of the valve, it may not be able to approximate properly, and we might even be having is blood leaking across the valve leaflets because of a defective coaptation. In fact, what I'm telling you at the moment, that is commissural end involvement, is one of the very important points of this discussion. One of the very important points from the medicine perspective from this discussion would be that what is the characteristic murmur that is seen with patients of rheumatic heart disease. Agreed that the commonest valvular lesion is mitral stenosis, we are gonna get a mid-diastolic murmur. But if he just says which of the following is the characteristic murmur or rheumatic etiology, then your answer is Carey-Coombs murmur. This Carey-Coombs murmur is a mid-diastolic murmur, and when I say that, I get a lot of mails saying, doctor, the way you drew it, let's assume this is left ventricle, this is left atria, the way you have shown the flow of blood goes from LV to LA. Normally blood will not go from LV to LA. In those patients where the blood will go from LV to LA, it will be in the phase of systole. So Carey-Coombs murmur should be a systolic murmur. I repeat again, how can blood go from LV to LA? Normal people blood does not go from LV to LA, blood goes from LV to aorta. If the blood will go from LV to LA, it should result in development of a systolic murmur, but Carey-Coombs murmur I told you is a diastolic murmur. So first I want to tell you that this valvulitis means that very minuscule amount of blood is leaking from LV to LA. We don't hear the sound of that minuscule amount of blood leaking from LV to LA, but gradually the blood keeps on accumulating in the LA, and the LA will keep on dilating. Now, once there's a substantial amount of blood accumulated in the left atria, all that blood will ultimately flow back into the left ventricle. I repeat again, the LA is getting dilated with a little bit of amount of blood that's coming into, and gradually the LA gets dilated, filled with the blood to the max capacity, and all this blood has nowhere else to go. So this blood will ultimately flow back into the left ventricle, and therefore I can say that this would be more of a flow murmur, in a sense that the flow maximum occurs in the middle of the diastole. I mean, when do you have filling of blood in the ventricles? The max filling of blood in the ventricles occurs in the middle part of the diastole. So the murmur that is heard here is not in the phase of systole. It is actually a diastolic murmur, because see, when little amount of blood is going from LV to LA, then some pulmonary circuit blood is also coming in the LA. So a combination of that blood from the lungs plus this extra blood that went from LV to LA will now cause a separation of the valve leaflets more than normal. And once this extra blood will rush through these valve leaflets, that's when you would get a mid-diastolic murmur. The murmur that I've described at the moment is different from the murmur of mitral stenosis. There the concept of murmur is totally different. Here I can just say at the moment is this would be a flow murmur, and if you're still having issues, I would suggest you to listen to the murmurs video where I've catered to this once again. The minimum concept that I would like you to remember is Carey-Coombs murmur is not a systolic murmur, it's a diastolic murmur. Why diastolic? Because the pulmonary circuit blood is also coming, and this little bit of blood from LV to LA which had accumulated in the left atrium of the patient is flowing back because it has nowhere else to go. Caricombs murmur is a characteristic murmur of rheumatic endocarditis, and this discussion also tells us a very important finding, which is that why should I wait for a person to develop mitral stenosis, or why should I wait for a kid to develop MR or AR clinically? Only when only when you hear a murmur, you will say the following lesions. The concept is, why should you let a patient suffer and develop a murmur? And this would also be dependent on the skill of a doctor whether he can hear it or not in a busy OPD. He says if you can identify valvulitis on echocardiography, that would help in early diagnosis. Guys, I'm telling you a very radical change that has occurred in the 2015 update for Jones criteria. Otherwise, they were unchanged from 1993. In Jones criteria, we always used to take into consideration clinical findings. We used to take into consideration Caricombs murmur, murmur of mitral regurgitation, murmur of aortic regurgitation in a patient. But now he says that echocardiography should also be considered. This is the first time that they have started incorporating echocardiography as a major diagnostic criteria for rheumatic etiology. Why are we doing that? Because we want an early diagnosis. If I'm able to identify the inflammation of the cusps, that's the tip of the valves, the commissure and inflammation, if I'm able to pick up, I don't need to wait for a substantial amount of murmur to develop and then say, okay, now I have a earth shattering news for you that you are having a damage to your heart. He says, do and go in for early identification. So echocardiography has been added, or echocardiographic evidence of valvulitis has been added to the major criteria for diagnosis of rheumatic fever. And I mean, in this slide, most of the stuff that I've said, you would have read it even in other subjects, barring a few aspects like LMNOP or maybe that ST elevation concavity upwards. The main reason on this slide why I went into describing the carditis component separately, other I would have straight away started from describing the Jones criteria, is just to sensitize you to the fact that we don't want to make the patient suffer and develop MR or AR, and then we say, okay, I mean, this is your diagnosis, heart valve lesion occurring due to rheumatic. We want to make an early diagnosis. Additional aspect which I would like to now draw to your attention is that can the right-sided heart valves be involved? Then the right-sided heart valve involvement can occur in these patients. The valve that is least commonly involved or unlikely to be involved is pulmonic valve. I'm not saying it's not involved, I'm saying least likely to be involved. See, the right side of the heart is ultimately linked to the left side of the heart. If the left side of the heart will suffer, if the left side of the heart will suffer, the pulmonary venous congestion will occur and ultimately the pressure will be transmitted to the right side of the heart also. So pulmonic and tricuspid valve involvement can occur in this condition. But the point to be remembered is that the pulmonic and the tricuspid valve involvement encountered in patients with rheumatic fever is secondary to the left-sided involvement. I mean, we are not going to have straight away Ashkoff nodules contributing to pulmonic regurgitation or tricuspid regurgitation. No, I'm not saying that. It is mainly due to the left side involvement, because left and right side of the heart are ultimately coupled to each other. So if the right side will suffer, then the left side is bound to, I mean, if the left will suffer, the right side will automatically suffer due to back pressure changes, and both sides are coupled to each other. If the right side will not function properly, see, the blood going to lungs will be lesser, cardiac output will be less. If the left side is not working properly, like due to MS or due to MR or due to combination, then pulmonary venous congestion will occur. This will affect the pulmonary artery pressure, pulmonary artery hypertension will occur, right ventricular hypertrophy will occur, and there's a limit to how much the right ventricle can ultimately get dilated. I mean, once it's working against a resistance, so there could be a subsequent dilation of the annulus of the tricuspid valve, and therefore tricuspid valve involvement or even tricuspid regurgitation can occur in these patients. See, it's very easy to understand. Most common valve involved, mitral valve. Second most common valve involved, aortic valve. Nobody has a problem with that. If he says which is least likely involved directly by Ashkoff nodules, then least to be involved in this patient would be the pulmonic valve. The basic concept is that if pulmonic valve will get involved, it will not be directly due to Ashkoff nodules contributing to damage or antibodies causing cross reactivity. It would be, if pulmonic and tricuspid are getting involved, then not directly because of the Ashkoff nodule impact. This is primarily because the left side got involved, left and right are coupled to each other, so the right side will also subsequently get involved in these patients. So I hope I was able to get these points right. Let me just focus on the core issues here once again, because endocarditis is the reason why this topic will be asked to you in the exam. Most common valve involved, mitral, you knew that. What's the commonest valvular lesion? Don't answer MS. Only if he specifies adult patient, if he talks about patient more than 18 years of age, it's MS. Otherwise, it is mitral regurgitation slash aortic regurgitation. Murmur of MR, pansystolic. Murmur of aortic regurgitation, depending on severity, can be early diastolic, or it could even be a mid diastolic murmur depending on the severity of aortic regurgitation. Don't wait for the valvular lesions to develop. Try to pick it up early. How? Not on the basis of Kerry-Coombs murmur, but with help of echocardiographic evidence of valvulitis in these patients, which is now included in the definition of, with carditis. Echocardiographic evidence is also taken as sufficient grounds for saying that, okay, we are taking into consideration one major criteria for diagnosis of rheumatic fever. Next up, we'll take into consideration the arthritis component, which is again a major diagnostic criteria. It would be the large joints of the body which would be involved. Unlike when it comes to rheumatoid arthritis, the topic we're discussing is rheumatic. In rheumatoid, you have a young female with PIP, MCP, and the wrist joint involved, and it's usually a bilateral involvement. Whereas in this case, it would usually be most of the time a asymmetrical involvement. The child could be having redness and inflammation. The joint will be hot and tender to touch. And which joints the child is not letting you touch would be like the knee joint or the ankle joint or the elbow joint. And there is also possibility that in the morning, the child was complaining of pain in the knee joint because of which he could not go to school. But in the evening round, you might notice the mother now is saying that his knee joint is better, but now he's complaining of pain in the elbow joint. So you will also notice that the joint pain and the inflammation and the redness might vary. On every consultation, when you ask which joint is hurting, today he was maybe saying the left knee joint, tomorrow he might say the right knee joint, and a day after, or maybe in the same day, tomorrow evening, he might say right ankle joint. So the arthritis component tends to jump from one large joint to another. The severity of pain in multiple joints involved can vary, and that's where the word is migratory polyarthritis, which basically means that the arthritis, the pain will move from one joint to another. Now, as far as polyarthritis is concerned, there is an interesting fact which is to be remembered. For a country like America, which would be a low risk population, because the disease is less common in that country, I need to demonstrate migratory polyarthritis of the large joints. But for a country like India, you can just notice, whatever I'm saying for India here is valid for any developing nation per se. But when I say moderate to high risk population, that would be like an Indian population, then because the disease is so common in our country, why should I wait for the child to have multiple large joint involvement and the demonstration of arthritis jumping from one joint to another? Why should I wait for 2 days to demonstrate that pattern of migratory polyarthritis? Even if an Indian kid who's having recurrent sore throats is from the low socioeconomic state of the society, is coming from slums, had a recurrent sore throat and today is not able to walk, and there's swelling of only one joint today. Even if it is a monoarthritis, it is sufficient ground for me to say that I'm dealing with a case of rheumatic arthritis. You see, they have subdivided the discussion into 2005-15 criteria into low risk population versus moderate to high risk population. Low risk population, developed countries. When I say moderate to high risk, developing countries like India, etc. The point is, we want to increase our diagnostic sensitivity. Why should I make an Indian child suffer? And over 2-3 days before I say, okay, multiple joint involvement jumping from one to another, so it is rheumatic. He says, even if it's a single joint involvement, take it to be a possibility of rheumatic. And obviously you will deploy the modified Jones criteria in totality before you make a diagnosis of rheumatic fever or a recurrence of it. As far as the definition of low risk is concerned, though this is taught in PSM, I thought I should mention it here, that there are two definitions, so be careful about the denominator. One of the definitions is less than 2 per 100,000, that is for school age children. But then if it is adjusted for entire population, then the denominator is not 100,000, it is going to be 1,000. So do have a look at the denominator part. For the lower part, which I'm underlining at the moment, this is age adjusted population for the entire population, and then would be primarily school age children. So with respect to high risk cases, it's monoarthritis that is sufficient. Obviously, if in India a kid is having that migratory polyarthritis component, great. By the time they came to me, maybe they went to some local practitioner, did not get relief. They came to me after 2-3 days of illness, and I'm able to, in the first consultation, pick up a migratory pattern, great. But he says that don't wait for this migratory polyarthritis component to be developing before you say that, okay, I'm dealing with a case of rheumatic. And similarly, lots of times you may not be even having a redness and inflammation of the joint. You may not have a joint that is red inflamed. It might just be joint pain. The mother is saying child is not able to walk because the child is limping, and you notice that there's a visible discomfort on the face of the child when you make him stand. So I'm writing also the word polyarthralgia. He says for a country like India, even if you're not able to demonstrate the presentation of arthritis, the difference between the two is understandable. I mean, in arthritis the joint will be red and inflamed and tender to touch. In arthralgia there may not be a very characteristic redness and inflammation of the joint, but it would still be hurting. So I would like to increase my diagnostic sensitivity by even including the word polyarthralgia for Indian population. The main concept here is that polyarthritis as well as polyarthralgia both make sense, but they have tried to segregate this with respect to an Indian perspective versus an American perspective. The Indian perspective, I'll repeat once again, is that we should not try and wait for the classical manifestation to occur. We should try to increase our diagnostic yield in a sense that even if it is a single joint redness tenderness or it is a multiple joint, only painful manifestations present, right? Only the main painful part component present, no redness, inflammation, we'll still take that into consideration for diagnosis. For the treatment of this arthritis component, we can be using aspirin. The only disadvantage of the aspirin would be that patient might develop gastritis and multiple dosing might be required. You will have to give it in multiple frequently divided dosages. So a lot of physicians nowadays do not use aspirin or acetyl salicylic acid in this case, and they might be more comfortable using naproxen. Next up is syndrome chorea. The question can say that in which area of the brain would the damage be present to cause manifestations of chorea. So you know that from your baseline physiology that chorea would be a distal involuntary movement. This would be a distal fast involuntary movement which would be found in the hands and the feet, and the person might be described as a fidgety or a restless person. This distal involuntary movement which is fast. In contrast, ethiotosis is a slow distal movement, whereas chorea would be a distal fast involuntary movement seen in the hands or feet, or might be described as fidgety because of the antibody induced damage to the caudate nucleus. The incidence of this will be relatively more common in female patients as compared to male patients, and these patients, female patients, when they conceive in future, they might even have a recurrence of chorea. There is also possibility that chorea may not develop immediately after a sore throat. Most of the time, by the time the chorea will develop, the history of sore throat would be conveniently forgotten. So I've written prolonged latent period after the person has suffered from infection with group A beta hemolytic streptococcus. Therefore, even antibody test can be negative because you see we can do a ASO titer, but the point is antibody titers will tend to decrease. So by the time chorea might appear, the ASO titers might have come back to normal. After the sore throat, which was the triggering event, ASO titers will rise. But antibody titer will fall and will tend, the antibody titers might be undetectable. ASO titer might be undetectable by the time the chorea manifestations will occur in a patient. One of the important manifestations of this fast involuntary movement would be that you'll ask this child, because chorea in these patients usually involves obviously the hands and can even involve the head. So in this, the child will keep on doing like this also, head movements also, and simultaneously the hand movements would also be present. So you ask this so-called fidgety, restless child that please stick your tongue out of your mouth. Like if you stick your tongue out of your mouth, you will just try to play and interact with the kid that, okay, take your tongue out of your mouth. Now you and me can stick our tongue out and we can keep it stationary, but in this case the tongue will not be stable. It might be going in and out of the mouth of a child like a lizard's tongue or like a frog's tongue. So I'm saying using the word darting tongue. Now because this is not a clinical exam and most of the time they ask you theory, so on the next point that I'm saying, I'm not going into the description of how would you be eliciting it, but yeah, we do read about darting tongue and pronator sign as manifestations that we see with syndrome chorea. Apart from this, you will also notice that on physical examination, normally a 10-year-old kid, when a doctor is examining him, is in awe of the doctor and he loves to at least look at your stethoscope or try to interact with you. Here the child will start crying very soon. Emotional lability will be present. Over and above this, with syndrome chorea, we might even be able to demonstrate obsessive compulsive behavior in the kids. So 4 manifestations I said for syndrome chorea, that is involuntary movements in the hand will anyway be present. But these involuntary movements may not only involve the hands and the feet of the patient, but even involve the head of the patient and even the control of the tongue. with respect to darting tongue, pronator sign, emotional ability, and obsessive compulsive behavior. Important point to be remembered is that 50% cases of chorea, earlier I was saying it's more common in women, now I'm telling you that patients who are having chorea, they might be having is evidence of carditis as well. Lots of time that carditis may not have been picked up because you see congestive heart failure will take some time to develop. A lot of patients might actually present with chorea at that point of time ASO titer would have turned normal, and they're having carditis component, they're having a murmur present, but it has not at the moment resulted in features. I mean, the child might be feeling tired early, he might be feeling breathless at times, and the parents might notice that he does not run as fast as other children. His capability to handle, I mean, the kid would be hampered, or his ability to play with the other children of the same age. I mean, he's not able to do the same kind of exercise capability as other children. But when you physically examine him, or if you do a echocardiography, 50% of cases who are presenting with chorea would be having evidence of carditis. As far as the treatment of chorea is concerned, that would be discussed subsequently. But yeah, we do have drugs. Lots of time it has a self-limiting course. If it is mild, if chorea is mild, if it's not interfering with eating or quality of life, no problem. I mean, chorea lots of time does not need treatment. It has a self-limiting course. But if it's gonna be limiting with respect to physical activity due to this involuntary movement, he can't write properly at school. And the parents are saying, sir, school people are saying that we'll chuck him out of school and he will fail in this class. I mean, he can't color properly. If you have involuntary movements in your hand, if the person's child is not able to draw properly, he's not able to color in a circle, then if it interferes with eating, then it's okay. I mean, I might be using drugs like valproate or carbamazepine, or we even use steroids for management of chorea. I told you steroids have no role in management of congestive heart failure. I'll write down the treatment part separately. You know, lots of time I say a lot of things which may not be written in your notes as well. That's just for you to imbibe that data. But finally, that information will be present in notes at some point of time. You know, I just can't go like a class 12th biology teacher, no, that's saying that, okay, fine, this is point number one, this is point number two, because our patients have a very wide presentation. So I have to be more descriptive about the way I see a patient, and I cannot go by the book and say point number one, point number two, as we do in, you know, in the junior classes or even in preclinical subjects as well. So that's a reason that lots of time in the notes the data might not be exactly the way I'm speaking, because I want you to listen and get that feel of, okay, how the patient is sitting and is moving his head and is, that's why I call it Saint Victor's dance, no, and the child is doing that hand movement and you're wondering, and parents are saying, sir, teacher is complaining, he doesn't listen to the teacher in class, he just keeps on doing this weird dance. And when you make him write, look at his handwriting, it's become very poor, because you know, basal ganglia help in coordinating our activity. Like if I have to write a particular alphabet, I wrote CAUDTE, caudate, then the size of alphabets was almost equal. How is it that when you write, the size of the alphabets is almost equal? That's because of the coordination of the various muscles. You are thinking, you are speaking, and you are writing, and basal ganglia is coordinating all of that activity. If basal ganglia malfunctions, that's when we start getting this varied clinical profile that I mentioned, which gender wise is more common in women, and the incidence of carditis component, which may not have been picked up or may not have become symptomatic enough, can be present in a large number of cases. As far as the skin features are concerned, there is hardly gonna be any question on this, because these are very unlikely to be seen nowadays. He says less than 5% of cases might be having the two manifestations of subcutaneous nodules or erythema marginatum. Subcutaneous nodules which are seen here are lumps which are going to be seen, like I mean, let's look at the location of the lumps. That would be more important. The location of the lumps is going to be extensor in distribution. When I say extensor in distribution, they will mostly be over the bony prominences, so you might be able to feel them over the hands of the patient, or you might be able to feel them over the olecranon process, sometimes with respect to the occiput, even I mean with respect to the tips of the spinous processes of the vertebra. So extensor distribution is where the subcutaneous nodules would be felt, and these lumps are also mobile in nature. Then another manifestation that is described in Western population, not in Indian population, because of the darker texture of the skin, is erythema marginatum. This erythema marginatum might be having serpiginous borders as well. This would be a pink macule. Macule means it's non-palpable. Papule is always palpable. This would be a pink macule. The pink macule might be having a central clearing. And when I say central clearing, the margins of this, I mean, this is a pink macule which is present on the skin. So you might be able to see the irregular margins of this pink macule with central clearing. So he might say serpiginous margins. I said this is not found in Indian patients, but still I'm describing it just for the sake of completion per se, having serpiginous margins. Another feature that we encounter here would be that the rash tends to appear and disappear. Like when the child is having fever, then this rash will be visible over the trunk. But once the fever will resolve after giving paracetamol, then we will notice that this pink rash will disappear. And as I said, I mean, you will require a fair skin. If somebody has a very fair skin, then this erythema marginata might be elicited. Next up is 2015 update of the modified Jones criteria, and we'll talk about how many major minor criteria would be required for diagnosis. And for initial acute rheumatic fever, you need presence of at least two major criteria, like the patient could be having arthritis and carditis. But there was a question which said which clinical manifestations cannot. He talked about the major criteria. He said which clinical major criteria for diagnosis of rheumatic fever cannot coexist in a patient simultaneously. Now, if you recall the earlier part of this video, I told you that arthritis occurs early and the chorea component develops late. If somebody is having arthritis, if a child is having rheumatic arthritis today, after 6 months, he can end up with development of chorea. So sequential involvement is possible, but simultaneously, arthritis and chorea cannot coexist. I repeat why the answer is like this. The reason for this being arthritis is the early, chorea is a late feature, so you can have a sequential involvement. The question said which cannot be present simultaneously. Arthritis and chorea cannot coexist simultaneously. There is also possibility that we may not be having two major criteria. Then we'll be using one major and two minor manifestations or criteria for diagnosis of acute rheumatic fever. The same data is also to be remembered for recurrence as well. But there is a catch in the recurrence. I also want you to remember that sometimes none of the major criteria may be present, and you might be able to identify a recurrence on the basis of three minor criteria as well. What I mean by the word same here is, and I'll just draw a vertical arrow to the point. I mean, for the recurrence part, obviously the standard data will very much be there because the disease is still the same. But lots of time, if you do not have a major criteria, but you're only having the minor ones, three of them to be precise, you could be talking about recurrence of acute rheumatic fever. And now I will focus on the major and the minor criteria from the perspective of low risk population versus moderate to high risk population. Low risk population would be a country like America, where incidence of sore throats would be relatively lesser, versus moderate to high risk would be like in India. Let me first put up the data, the major criteria for the low risk population, and that is invariably the carditis component. I have spoken about perimyocarditis and endocarditis, with endocarditis being a hallmark feature. I want you to remember that carditis could be picked up clinically, in a sense that you could have a acute congestive heart failure, you could have development of valvular lesions as well. So clinically detectable, or instead of just being clinically detectable because manifestations develop late, so there could even be echocardiographic evidence. By echocardiographic evidence, I mean you could be demonstrating presence of Carey-Coombs murmur or incidence of or presence of valvulitis. Then even if it is valvulitis implies subclinical carditis. I repeat again, valvulitis is the initial presentation. There are no clinical features at this point of time, but there is a predisposition of the Ashcroft nodules to involve the cusp of the valves. So valvulitis has been included as a major criteria. And the way I've written the data, I'm just trying to say here at the moment that carditis for both low risk population and high risk population is the same, which is the reason for the spillover. But there will be a small difference with point number 2. When I describe the arthritis component for a low risk population, I need to demonstrate that classical migratory polyarthritis involving the large joints. I need to demonstrate that the kid is telling the mother and the mother is telling to you, or if it's older kid, he can tell you directly that the pain, let me say in the morning round, was prominent on the ankle joint of the patient, that on the same day, evening round, or maybe the next day, the joint, the position of the inflammation, redness, tenderness might actually change. So migratory polyarthritis is a must for diagnosis in low risk population. But if we come to Indian population, because I want to increase the diagnostic yield, I will not wait for that classical profile of migratory polyarthritis to develop. Even if an Indian patient is having a monoarthritis, that is sufficient for diagnosis. Obviously, if an Indian patient is having polyarthritis, I mean, I'm more happy, I'm always satisfied because that's the standard diagnostic criteria. But the add-on is 2015 update. Earlier, we always used to read migratory polyarthritis irrespective of the population. Now he has said that for Indian population, monoarthritis is to be considered. An additional point which is to be remembered here is also polyarthralgia. I'll tell you the significance of this a little later, but at the moment I can say, suppose you're not able to demonstrate the redness and the inflammation, but the pain is still there, I'll still take that as a major criteria for diagnosis, but only for when you have a high risk population present. Apart from this, you would be having presence of syndonyms chorea, where there would be involuntary distal movements present. The same chorea would be present on the right hand side as well. So there are no surprises with respect to chorea or the skin manifestations. There were two of them. The skin manifestations was subcutaneous nodules, and then was I'm writing, that is erythema marginatum, which is usually not found in Indian population. So you would not have any trouble with respect to chorea, subcutaneous nodules, erythema marginatum. You would not have any problem with respect to the carditis component. The main aspect, I mean, where the MCQ will try to trick you is only with respect to these words. And the logic to be used is simple and straightforward. For a population where the incidence of sore throats is lesser, we'll go for classical manifestation. For a high risk population, we might tend to deviate from the classical manifestation and include monoarthritis slash polyarthralgia as a major criteria. We'll now focus on the minor criteria ones, which are important from the exam perspective again. So let's look at some of the laboratory parameters and physical examination findings that would come up here. One is obviously presence of fever, because we are dealing with a patient who's having an inflammatory condition, so fever is bound to be present. And I did tell you the fact that erythema marginatum rash tends to appear and disappear. When child is having fever, you will find mother will say, look at the rash in the body. I mean, I'm talking from a perspective of American kid. Mother will say that, doctor, look at the rash on the trunk of the child. But once you give acetyl salicylic acid, paracetamol, whichever is available, fever goes down, the rash also tends to settle down. The cutoff for fever is to be taken for a population like a low risk population is slightly higher. It's 38.5 degrees Celsius. Whereas when it comes to high risk population, the cutoff used is 38, just a minor point, but yes, worth remembering. Then we'll take into consideration elevated ESR. When I was a student your age, all I used to read was elevated ESR. There was no cutoff. But now he mentions that for American population, the cutoff to be used would be 60 millimeter fall of ESR in first hour. Whereas for Indian population, he says even if it is more than 30, I'll write it down in a while. He says for Indian population, even if it's 30, no problems, make a diagnosis because of higher incidence of infection. We used to read CRP positive. That's again still the case. But here he has mentioned a mathematical value. I don't think that in the exam he's going to put up a value like more than three values here specifically. I mean, it's very, very unlikely that he is going to trouble you with the value perspective. But still, just for the sake of completion, I should mention this here. That would be 3 milligram per deciliter. And then comes the important aspect, which is very neglected, that Ashcroft nodules would be damaging the conduction system of the heart. The Ashcroft nodules can be present between the SA and the AV node, and if you have Ashcroft nodules, inflammatory nodules, the speed of conduction will be slow, and due to this slowness of conduction, the PR interval of the patient. Normal PR interval is 120 to 200, 200 milliseconds. In this case, there would be a increase or there would be a prolongation of the PR interval of the patient. Over and above this, you will also be noticing that these patients could be having polyarthralgia. Now that's the catch which I want you to listen to once again. You see, just a few minutes ago, I was telling you polyarthralgia is to be considered as a major diagnostic criteria for Indian population. And now I'm telling you polyarthralgia is a minor criteria, but for low risk population, and lots of people mess up on this. So if I just zoom up, I would say zoom out of the slide, you will notice the word polyarthralgia coming 2 times. And most of the time, they can be error of judgments. The learning for you guys is for American population. My suggestion is try to remember it from the American perspective because the disease is, sore throats are less common. So we'll go by the classical finding of migratory polyarthritis, that is major. But suppose it says polyarthralgia in an American kid, I'll take that as a minor criteria. But for Indian patient, because the incidence of disease being relatively higher, sore throats being more frequent, I need a high index of suspicion, no issues. I mean, polyarthralgia would be included in the major criteria. Let's now focus on the minor criteria on the right hand side, and I'll let you remember the subtle differences. That would be fever, which is a little more than 38 degrees Celsius. I'm not saying that that's a very accurate way, the 38 and 38.5, but he's trying to introduce a differential, and these differentials can be pretty irritating when it comes to remembering MCQs, because in this case, the ESR fall that we're taking into consideration is about 30 millimeter fall in the first hour. There is no surprises for the value of CRP. He says CRP values more than 3 milligram per deciliter. Even the PR interval of this patient would be showing a prolongation. The reason for that, I said, was that there are Ashkoff nodules between the SA node and the AV node, so the conduction part would be relatively slow. And then another feature that can be incorporated here is monoarthralgia. So most of the time, with respect to this data that I have said, nobody has a problem with respect to remembering ESR cutoffs or CRP or prolongation of the PR interval. That's pretty straightforward. It is just that the examiner loves to trouble you with the words like polyarthritis and polyarthralgia. And the best way, or I can say the best hack to remember this is simply go for the classical manifestations, and in case it's going to be polyarthralgia written in a Western setup, then you will take into consideration polyarthralgia as a minor criteria. However, with the rest, for our Indian scenario, polyarthralgia is a major one and monoarthralgia is a minor one. So try to put some focus here, and you would be on your way to getting the modified Jones criteria right. No problems with carditis. That's standard. Chorea, subcutaneous nodules, erythema marginatum, standard information. They just play around with these arthritis manifestations that I've explained, or they can just try and trouble you with these mathematical cutoffs, though unlikely. I mean, it would be unjustified on the part of the examiner to trouble you with a 60 millimeter fall versus a 30 millimeter fall, though I've tried to even justify that as well. And in fact, in my opinion, I mean, if he wants to test you with the minor criteria, this is the one that he should quiz you about. That is prolongation of PR interval in excess of 200 milliseconds, or he might deliberately write this as presence of first degree heart block demonstrated on ECG because of slowing of conduction between the SA node and the AV node. We will next focus on a couple of because no single investigation will help in diagnosis. So we will run a battery of tests, and he says which test must always be written or requested by you to the laboratory so that you can be saying with confidence, okay, I'm dealing with a case of acute rheumatic fever or its recurrence. One is obviously a ECG, which will be showing presence of prolongation of the PR interval, echocardiography, which can show either a MR or a aortic regurgitation, which are the two common lesions present. Sometimes in older patients, mitral stenosis can also be present. I'll be doing a complete blood count in a patient because TLC can also be increased in these patients. And because there was a bacteria which is responsible here, so I would also like to do some test which can give me some evidence that, okay, there was a bacteria which resulted in cross-reacting antibodies to be produced. And therefore, it would be imperative that in all cases, we also go in for streptococcal serology. For streptococcal serology, there are two tests which are available. One of them is obviously ASO, so I'm just writing that, anti-streptolysin. Or instead of this, I can go in for another test as well. And the more tests I write in a scenario of evidence-based medicine, I give more credibility to my diagnosis. So anti-DNA ASB antibody would also help in increasing the credibility of diagnosis. Then he says, what test should you write to exclude alternate diagnosis? Then there are a couple of them. Let's just jot them down, the alternate ones. The first is obviously an autoimmune profile, because the person, let me say, if you are having a female patient and she's having arthritis, then you could be considering multiple rheumatological disorders which can be taken into consideration. One of them would be obviously lupus. So I've written double-stranded DNA. And then because it's a female patient, and if she's having a small joint involvement of the PIP, MCP, wrist joint bilaterally, then it would be anti-CCP antibody, that is cyclic citrulline peptide antibody. So these tests are mainly being written for differential with respect to either a lupus contributing to arthritis or rheumatoid arthritis per se. Rheumatoid arthritis, CCP antibody is anti-cyclic citrulline peptide antibody. It is more accurate as compared to RA factor, because RA factor lots of time can be biologically false positive as well. Similarly, I would also like to test the urine of the patient, because you could be having a young female having reactive arthritis. So he says, considering the possibility of reactive arthritis, we should rule out, especially or evaluate this lady because she might have been exposed following unprotected sexual exposure to Chlamydia trachomatis, which is not only a important cause of PID, but is also documented to result in development of reactive arthritis. So we can be doing some molecular test, we can be doing a nucleic acid amplification technology, and we can demonstrate the presence of this organism. Then he says that apart from this, you can run a couple of serological tests because arthritis is again having a varied reasons for manifestations of or involvement of the joints. So we can be doing testing for cytomegalovirus or testing for parvovirus, testing for even viral hepatitis, because extra hepatic manifestation of viral hepatitis could be a joint presentation as well. So mainly the inferior part was to rule out possibility of, let me say, autoimmune rheumatological disorders, or instead of rheumatic disorders, I can say reactive arthritis, or maybe a viral cause which could be contributing to a viral arthritis in a patient as well. This, in this particular slide, the superior part that I mentioned, investigations that must be ordered are ECG, echo, CBC, and streptococcal serology. I mean, streptococcal serology is one of the very important tests that will help in improving the credibility of diagnosis. And now we'll be in a better position to talk about the treatment of this condition. For the management of this condition, if we talks about primary prevention with antibiotics, we can be either using amoxicillin or we can be using ampicillin, or if not available, a low cost option would be phenoxymethyl penicillin. I'm talking about oral penicillin to be administered to this patient who is having a sore throat. And this antibiotic therapy ideally should be started as early as possible. He says if you start within 9 days of a sore throat, this they have documented on multiple clinical studies that if these antibiotics are started within 9 days of onset of a sore throat, then the chances of development of rheumatic fever and the cross-reactive antibodies almost becomes zero. So primary prevention, I mean, look at the words carefully, whether he's asking about secondary prevention, which I started right in the beginning, that's going to be injections of benzathine penicillin. This is what I've spoken regarding primary prevention. The next drug we'll be using in this condition is aspirin, that is acetyl salicylic acid. This will be mainly used for management of arthritis and the polyarthralgia component that could be present in these patients. And the biggest problem with aspirin would be the GI irritation or the development of erosive gastritis. Because of this, we need to watch the patient for possibility of even a GI bleed. And apart from this, they also love to ask you about salicylate toxicity, which can be development of metabolic acidosis. Easy to remember because it is acetyl salicylic acid. So there would be a metabolic acidosis with a compensatory respiratory alkalosis. Another problem with aspirin would be that multiple dosing would be required per day to get sufficient amount of analgesia. So a lot of physicians, they prefer using naproxen. I'm not saying that naproxen will not cause erosive gastritis. Both naproxen and aspirin are notorious to cause development of erosive gastritis. It is only that the aspirin has in contrast to aspirin, which might be required to be given 4 times per day or even maybe 5 or 6 times per day, naproxen might be required to be given only 2 times per day. So a lot of physicians prefer, because erosive gastritis effect is going to be, the side effect is going to be constant factor anyway. So I would like to use a drug where the number of dosages required per day will be lesser. That will improve the compliance part and will give more, I would say, rest, or will make the patient feel more comfortable because the tablet is acting for a relatively longer duration. As far as the role of steroids is concerned, I sensitized you to this initially also, that he says the role of steroids usually remains controversial, though a lot of physicians would still be using it. There have been 2 meta-analyses which have failed to demonstrate any kind of benefit in improving either a short-term or a long-term outcome of the carditis component. Though the biggest problem is, carditis, what will it cause? Carditis will ultimately contribute to congestive heart failure. So there have been, couple of physicians who will continuously use steroids even congestive heart failure. But if a person is having acute congestive heart failure, then steroids alone will not mitigate or will not reduce the short-term mortality, or they're not going to reduce the pulmonary edema component. Steroids can be useful for pericarditis component, understandable, but for myocarditis component, or there is a valvular lesion which is causing it, then we need to use standard LMNOP. That would be Lasix, morphine, nitrates. Morphine, because morphine reduces pulmonary edema. I'm not giving it for chest pain. I'm giving it because it will reduce pulmonary edema. I'll be using nitrates in this case, anyway, oxygen, and then positioning of the patient. By positioning, I imply that the head end of the patient, let me just draw it crudely also, the head end of the patient will be kept at a higher level. This is to minimize the chances of development of orthopnea. So acute congestive heart failure per se would be managed with, or acute pulmonary edema will be managed with LMNOP. As far as the role of bed rest for this condition is concerned, in earlier times the textbook always used to mention strict bed rest, but now he says that the moment the naproxen or aspirin tablet will start having its effect, the arthritis component will subside or the arthralgia component will subside. So wherever possible, minimal amount of mobility should be allowed in the patient. That's mainly because you can understand any bedridden patient, chances of deep vein thrombosis will be there. So strict bed rest is not recommended for these patients. Coming to the chorea component, he says that if it is mild, it is not debilitating, then most of the time providing a calm environment will help, and it will help a self-limiting course. No treatment would be required. But if he says that this will interfere with day-to-day activity, including even the feeding of the child, he cannot eat by himself, then in moderate to severe chorea, we might be forced to use drugs. The drugs which we can be using are like carbamazepine. We use it in focal seizures and even for trigeminal neuralgia. We can be using valproate. And well, the biggest problem with them would be sedation. In earlier times, when I was a student, I used to read about haloperidol being the initial approach for management of chorea. But now I've written it subsequently mainly because of the problem of drug-induced Parkinsonism. So haloperidol is effective, that's okay, but there is a sedation component. Plus, there can be risk of development of drug-induced Parkinsonism. So it has been written subsequently. Apart from this, clinical studies have shown that a large number of chorea patients can be having concomitant carditis as well. I sensitized you to that earlier also. So when a person is having syndrome's chorea, echocardiography should be done to detect maybe a valvulitis or a carditis which has not resulted in frank clinical manifestations in a patient. They have also said that if steroids are used, then steroids will just cause a faster resolution. Again, the indication for using steroids would be a person who's having a moderate to a severe, I would say go more towards severe chorea. That's where steroids would be effective. And if he says about medically refractory, like you have tried all of these drugs, the chorea is severe enough to contribute to severe disability, there's a medically refractory chorea, then he says that even intravenous immunoglobulins can be used. In fact, has been asked in the exam in the previous years that you've tried everything available for management of chorea, but nothing works. Then the medical refractory chorea, IVIG is to be used. There is no impact again on the carditis component. It's not that steroids or IVIG that I'm talking. I said chorea and carditis could be present in a case. 50% of cases with chorea, there is a possibility of having a carditis which may not be clinically symptomatic. When you will give steroids or IVIG, it will not affect the course of progression of carditis in a patient. But it has been shown to, especially steroids, have been shown to cause a faster resolution of the chorea component. And usually, wherever possible, first approach is always to be answered as self-limiting course and a calm environment to be provided, support to the patient and support to the parents to be provided so that they're educated about the disease the child is suffering from. And coming to the AHA guidelines for secondary prophylaxis, we shall be in this particular case giving long-acting penicillin, that is shots of benzothine penicillin would be administered to the child. The range at which the injections of benzothine penicillin would be given intramuscularly will range between 3 to 4 weeks, though he says that for high risk cases, you might be giving penicillin as early as 2 weeks. I repeat the facts once again on the slide. One, I said that though the range is between 2 to 4 weeks, I've written 3 to 4 weeks because that's the conventional norm. But suppose a kid is having MR and AR, and I don't want those valvular lesions to worsen, and I don't want a recurrent sore throat, so I'll tell the mother come every 2 weeks. There's a possibility the mother may not come every 2 weeks. She may delay it because as Indian patients do marriage in the family, festival in the family, I don't have time, something like that. So I want that at least in 1 month period because the effect of medicine will last for 1 month. They would be this benzothine penicillin will cause a minimal inhibitory concentration in the blood of the patient that will prevent colonization of the throat by group A streptococcus. So I want the mother to be compliant and regular in her follow-ups, and we should always write this word after test dose whenever we are giving benzothine penicillin. Suppose the child was receiving benzathine penicillin for one continuous years, and every time dose was being given, nothing happened in the kid, and he received penicillin, went back home after observation period, and there were no problems. And maybe after 1 year, your staff nurse was changed, and the new nurse did not read your orders properly, and she gave penicillin to the patient without giving a test dose, thinking that this child, because in the prescription multiple dates will be written, this child has received penicillin for last one whole year, and therefore I don't need to give a test dose because nothing has happened. And unfortunately, all hell breaks loose, because the moment she will give it, there is a possibility that the lips of the child will turn blue, and this child can even die. You must always give a test dose before you give penicillin, ideally recommended before every shot of penicillin. Otherwise, anaphylaxis will always be there or can be there, and you never know when it will occur. Anaphylaxis with penicillin is very unpredictable. The reason for death after anaphylactic shock can be laryngeal edema, and once that develops in the MCQ, laryngospasm will also be there, laryngeal edema will also be there. Histamine is being liberated here, so therefore laryngeal edema will be a profile or manifestation. The lips will turn blue, and you cannot even intubate in a patient. Anaphylaxis is mediated by a which cell? Then you know from pathology, do not answer eosinophil. Do not answer eosinophil. Anaphylaxis would be mediated by basophils. The cytokine which would be involved in this case is interleukin 4. So a couple of, I would say, pathology based aspects. And for management of anaphylactic shock, what would you do? So you will break open the ampule of adrenaline and you will give it undiluted. The only scenario in emergency medicine where you give undiluted adrenaline is for an anaphylactic shock. Every time else, every time for cardiac arrest, or even in patients of pulsus electrical activity or ventricular fibrillation, ventricular tachycardia, wherever I have talked about adrenaline, it has always been diluted. The only scenario where I'm speaking about undiluted adrenaline is right now. You break open the ampule, half of it, 0.5 ml IM adrenaline would be given undiluted to the patient, because we want a rapid onset and you don't want to waste time securing IV access, because histamine will cause vasodilation. As far as the durations for which the antibiotics would be required have already been discussed. I have talked about the traditional data, rheumatic heart disease with a valvular region demonstrated clinically or echocardiographically. The injections would be given till 40 years of age, if not agreed, 10 years since the last attack, whichever is longer. This word always has to be remembered, whichever is longer. So I mean, I want to increase the duration of secondary prophylaxis. If it's gonna be with carditis, then the injections will be 21 years or up to 10 years, whichever is longer. And without carditis, which has been the standard question, then either till 21 years of age or at least till 5 years. I mean, obviously the first answer would be 21 years. And every time we are giving this injection, I would prefer that test dose would be given. Otherwise, anaphylactic shock can occur. Coming towards the end of this discussion, he can mention regarding echocardiographic evidence of rheumatic carditis, though this has overlap from radiology. Still, I would like to do my part by mentioning that though the valvulitis part is for subclinical one, if there is a frank clinical echocardiographically demonstrated MR, then when would we call it a pathological mitral regurgitation? So one of the findings would be that blood would be leaking from LV to LA. The radiologist will be able to evaluate the jet length, and the jet length should be more than 2 centimeter. Apart from this, because there is blood leaking from a high pressure chamber, that is left ventricle, to low pressure chamber, that is left atria, there would always be a high velocity blood. So on echocardiography, you can measure the velocity as well, and the velocity should be demonstrated to be more than 3 meter per second. And this jet of blood that would be moving from the LV to LA will be during the phase of systole, so pansystolic. Similarly, you will read about pathological aortic regurgitation in a patient. For pathological aortic regurgitation, the blood will be leaking from the aorta back into the left ventricle. The jet length would be more than 1 centimeter. As far as the peak velocity is concerned, it would be a similar value, 3 meter. So if you can remember, it's okay. Otherwise, you can let this go at least for the first time, because you sometimes have to listen to lectures more than once also. So if you're listening for this for the first time, you can forget these values. If you're listening for the second time, the numbers to remember are 23 and 13. 23 is for MR, that's the values that I mentioned, jet length and the amount of velocity of blood. And 13 is the number for pathological aortic regurgitation. Apart from this, I can also demonstrate presence of mitral stenosis. For mitral stenosis, the mathematical gradient between the left atria and the left ventricle should be at least more than 4 millimeter of mercury. So these are a couple of, I would say, echocardiographic evidence of rheumatic carditis. If we say subclinical carditis, then the answer is valvulitis. But there would be a frank MR and AR that can be developing in these patients, and in later patients, older patients, they can also be possibility of development of mitral stenosis. So these are the details that I would like you to remember for this topic. Most of the questions on this topic will talk about either primary or secondary prevention, or we'll talk about the criteria that I've tried to explain to you, though they have been discussed in other subjects also, but I've tried to give them more of a medicine perspective. So thank you so much for your patience. Keep hammering, keep the pressure on. And I know that you guys are brilliant chaps, you're doing great, but then we tend to get a little, after studying for a few days, there comes a phase when hardly any study happens, and that is those phases you have to minimize. Obviously, I mean, brain will get saturated, but my only advice to you when I say the word keep hammering is that try to be consistent and try to put in a fixed number of hours, minimum number of hours per day at least should be determined, so that at least we don't get into that feel that, okay, I did not study for a few days, so the subsequent days can also go wasted. So these would be a couple of tips from my side just to increase your performance and your productivity. Thanks once again for hearing me out.